Welcome everyone to this another episode of Surginar, and Surginars have always been very popular, mainly because they are live surgeries which are actually relayed from the operation theaters after doing them immediately. And so it is like entering into other people's operation theater at your own desktops, laptops, or mobiles.
इकट्ठा
So
लगेगा वेबिनार है
it is, we are going to have deferred live surgeries with new freeform diffractive intraocular lens technology. And I have with me my
म्यूट कर
co-moderator, Dr. Anaga Harur, who is the managing director of Anil Eye Hospital, Mumbai, which has many branches now in Maharashtra. And she's also the member of the All India Ophthalmic Society Scientific Committee, as well as also the president of the Maharashtra Ophthalmological Society. And apart from that, I have the surgeons who are going to be operating today. And the surgeons are Dr. Rajiv Chaudhary, Dr. Virendra Agarwal, and we also have just a second. And we in fact are going to have two surgeries which will be done on ODC IOL, and then another one which is going to be done on the pure CIOL. So I think without much ado, I would request Dr. Anaga Ru to take over and to introduce the speakers and the panelists for this session.
Thank you so much, ma'am. Good evening and welcome one and all to this Surginar. So today it would be on the Freeform diffractive platform as well as the J&J other lenses. So we have esteemed surgeons today here as well as esteemed expert panelists. So our first surgeon is Dr. Rajiv Chaudhary sir, who is the director of Rajasai Hospital, Indore. Followed by Dr. Virendra Agarwal sir, who is the MD and Chief Consultant Eye Surgeon, Dr. Virendra Laser and Phaco Center, Jaipur, and followed by Dr. Amit Mishra, who is also a consultant at the Dr. Virendra Laser Phaco Surgery Center, Jaipur. Joining us are our expert panelists, Dr. Manohar Mehta, who is the director of the Mehta Eye Center Hospital, Bellary, Karnataka, Dr. Satyaprakash Tiwari sir, who is the director, Drishtipunj Eye Hospital, Patna, and Dr. Rakesh Gupta, who is the chairman and managing director of the Shreya Eye Center, Delhi. So without much ado, I would request our first surgeon, Dr. Rajiv Chaudhary sir, to please start his surgery.
Good afternoon to all the panelists. I will going to show the video on the Odyssey. It was a 44-year female. Can you start the video? 44-year female, hypermetropic, grade 2 cataract, and looking to her circumstances, initial presbyopic, we advise him to go for near correction glasses, lenses to correct the near glasses also. So advise him for Odyssey. We have the option of using the other trifocal head-off lenses also, but depending on her condition, we advise him so that she can get a good near vision also. I have used Odyssey recently, around 10, 12 lenses. I am used to using Pure C and Symphony Synergy lenses much, and all are giving the good result with some improvement in each and everybody. We have used Pure C also, Odyssey also. Odyssey giving the good near vision with the minimum glare and photopsia. So this is the draping, our theater with all sterilized condition. Surgery done in the topical Centurion machine. I am using the temporal incision. Patient was quite cooperative. And is gradually our increase for the requirement for the presbyopic correcting lenses. So started the surgery. You can see grade 2 cataract. Topical. I use side port and 2.2 incision. I extend my side port and 2.2 knife so that while re-entering, we can get the clear side demarcation. Cleaning the visco and discharge. This is side port. Stand with this standing. So that again, when we want to re-enter, we have clear standing points at where is the incision, because it's sometimes that clear corneal and clear incision, it is sometimes difficult to find the site of the incision. So I always stand the incision, just putting one drop of standing over the knife. Same is with the 2.2, using good viscosity. High visc is that so that it give a good pressure over the lens and our rexis will be smooth. After inflating, I do rexis with the forceps around 6 mm. Then hydrodissection. Repeated hydrodissection because the cortex is soft, so we want clear differentiation between the cortex and the capsule. Viscoelastic. And then rotate the nucleus with the hook. So separate it from the capsule. And good rotation give the clear site for the phacoemulsification. 2.2. Torsional phaco. As the cataract is soft, so much power is not required. Separating. Sometimes the soft cataract, we should be more careful so that we should not injure the posterior capsule, as the machines are good. So now the problem of surges are not much there, but still you should be careful for and gently, because the soft cataract is there, so we should take it carefully, should not hurry. Nucleus is out. Cortical kinning. I used coaxial irrigation aspiration cannula curved so that I can easily aspirate it from the subincisional area also. I will prefer the coaxial more than bimanual. So anti-capsule polishing as much as you can do. Posterior capsule polishing. There is a small stick of posterior capsule opacity there. We'll try to clean it with the polisher and then with the gentle wash. Then this is a ODC 24 diopter lens with the injector system. And a good injector system. Already preloaded incision. Preloaded lenses are there. And so by rotation, it easily go inside the bag. Sometimes it is too loop stick and you need to get it separate with the spatula and hook. And the ODC lens has 15 rings. The advantage of ODC is over the Synergy is that height of these rings are reduced 50%. So the vision become more smooth and they are utilizing around 95% of the light instead of the 88% in the Synergy. So much utilization of the light, less glare and halos, and very good near and distant vision. Already these lenses are foregoing for minor distance and near correction, 0.5 plus minus minor distance myopic or hypermetropic error. They are foregoing for, and they can take care of the 0.5 diopter error for distance also. So this is the lens well placed. We can show you the ring polishing. Again, polish the way with the, there is a small stick in the posterior capsule is tough. We will leave it as such. And then again cleaning. So clean the viscoelastic also.
Excellent surgical demonstration, sir.
Hydro work.
Very nice
The
surgery.
surgery. It's over.
Thank you. Thank you very much, sir. Very nice surgery.
Okay.
Thank you so much.
Thank you. Thank you.
Excellent. Yeah, yeah.
Okay.
Since the second surgery also would be on the same lens, I would request
Okay.
Dr. Virendra Agarwal, sir, to please go ahead with his surgery so that we can have a discussion together on this. So we have our chairperson, Dr. Namrata Sharma, ma'am, who is the professor at the RP Center, AIMS, New Delhi, with us. Very accomplished and brilliant surgeon and chairperson scientific committee. Dr. Virendra, sir, are you ready, sir? Dr. Virendra, sir?
Dr. Virendra or Dr. Amit Mishra? Virendra is there. Yes.
Yeah, I'm ready.
Yes, sir. Please, please. Yes.
Sir,
If you can please go ahead. Yes, sir. Yes, sir.
So can you see my screen? What was the age patient का PowerPoint में?
Yes, yes. Now it is seen, sir.
Just a second. So the patient is actually 61-year-old female. She is gynecologist by profession, wants independence from glasses, and she is having a normal parameters in the sense of the topography, height trace, pentagram, and the OCT. The both are good. So I think she is a right candidate, and she wants independence also. And as such, also my first choice for all the patients, those who want to get rid of glasses, is this, that we should have some kind of the lenses which are premium in category by means of giving the comfort either by having a lenses with the rings and or read-offs. I am using Synergy and other multifocal trifocal lenses for long, and I was happy with them also. But gradually, I learned that the few patients who are having some or other reasons of not choosing it, and the market is showing that the lenses which are having dysphotopsia are not the first choice. So I think with that concept in my mind and in the patient's confusion mind, this Odyssey or the free form of diffractive lens is working very fine. As Dr. Rajiv sir said that he is doing scanning, it is a good idea. And whenever I do usually live surgery, I try to use the stent for all patients, so the track becomes good. But sometimes the track, when we try to do a very smaller track, may have some issues with the negotiation while entering with the cannulas for the viscoelastic. Majority of the surgeries I still do in HPMC. Definitely, for some reasons, if there is a reason, logic behind it, then I use conductive sulfate and other mixed kind of viscoelastics. But majority of the patients, when we do surgeries for premium cases, are actually very soft cataracts, don't require much of the energy. And many of the patients are now we are doing with the femtosecond laser assisted cataract surgery. With this, the further use of ultrasound power gets down and down. And because of that, I feel that many of the time the higher viscoelastics are not needed, but definitely they have some advantage and indications. In those cases, I still prefer. And I prefer to have a Rexis of around 5.5, and sometime it goes a little small, sometime bigger, but we want to be covering the IOL optic all around 360-degree, so the Rexis should not be too big. Definitely, if you are going to have a smaller Rexis, it may give a problems of phimosis. So we want to be on a balance. And for that balance, I recommend that around 5 to 5.5 should be your aim. Sometimes it may not be that well centered, that if you do a little large, it may be having a one edge which is not covering. So it is better to be on little smaller, but not too small. And every time when we want what to do is usually not achieved, but majority of the time now almost all surgeons can achieve a right rexis, which means a continuous, which means a kind of center and an appropriate size. Different people have their own choices for the size. So that is also one thing. It is also a very soft cataract, as Dr. Rajiv sir has shown. And the soft cataracts, it is usually difficult to do a chop. So I also feel a little struggle, but definitely I do with the low parameters. So it should not have issues, problems to the cornea, to the posterior capsule, and to the surgeon. As such, also I am a very little slow surgeon, and I want to keep my patience also. So it is better to give 1 or 2 minutes extra on table for the safety of the patient, and first post-op day happiness, and a longer time of clear vision, not getting compromised by the corneal issues. And of course, definitely these lenses are very sensitive to posterior capsule opacification. So at the end, I will try to show you some polishing. Everybody is having some different techniques or a system by which they do polishing. I am directly not a fan of direct chop. I prefer to do something like stop and chop, or I make a little groove and then try to divide. Majority of the patients, I do a central chop. This is not a choppable nucleus, but I'm trying that if I can negotiate something. The parameters you can see, the vacuum is 200, power I'm using is just 30, and the flow rate is also not very high. There are fast surgeons who can keep these parameters on a higher side. But my recommendation to all is that unless you are very comfortable with the high parameters, we should not bring our ego into it that we are going to use high parameters. or the parameters which are going to work faster and save few minutes. But I feel it is a kind of surgery for patient which is very important. Every surgery is very important, but what I mean is that just your 1 or 2 minutes, if not give you results, the way you can actually deliver is not very justified. So I'm trying to do catch hold of something to make it a crack, but you can see that it is cheese wiring. It is a soft catheter going behind. Again, so I have to come back. I reduce the power, I reduce the vacuum. Still, I'm not able to get, but now I'm getting one crack. So I will try to divide into 4 or 6 pieces or whatever number of pieces I can divide. But sometime I end up not having a very good divisions. But these kind of aspirable catheters, when you get one nucleus piece out, the rest can be just kind of aspirated. It may not look very decent and nice as we do in grade 3, grade 4 catheters, having a piece by piece phacoemulsification, which is impressive also, though it may give some time because of higher power requirement, some issues, but most of the time we are able to manage. So patience is the key. I prefer to give my message and request everyone, those who are very good surgeons, they can do their own way, but the people who are having a patience in whom they want to deliver, and you have to definitely implant a lens which you have promised to the patient, be slow, and this is the trick. And at the end, you can remove all the pieces, the nucleus, the cortex, and then we'll end up into having a IA only. This kind of epinucleus, though it was there, but I was not able to chop the nucleus pieces. So these kind of things may happen. We have not implanted many in the number, almost I think 25 or odd ODC lenses we have implanted. Very few are toric into that. But definitely my suggestion is that whenever you are implanting these kind of lenses, the astigmatism is a big culprit if the patient is not happy. What I mean to say is that at the end, my aim is that I should have a less than 0.5 cylinder or up to 0.5 cylinder, and minus 0.5 cylinder at the 90-degree axis in the glasses will be forgiven more often and will give increased depth of focus, increased working range. So whenever I'm thinking that the result is not going to be the same way, I definitely use toric lenses. And now we are lucky that the toric lenses are available to treat with such platforms with a very low power diopter also. Means 0.7, 0.75 diopter can be treated by ODC or synergy lenses. So that is a advantage to us to deliver better results for the patients. I use bimanual irrigation aspiration in almost all patients, and I feel that this is the way to clean the capsular bag all 360 degree of the cortical matter and even the polishing also. In polishing, there are different means, but since beginning, I am suggesting that I use sandblasted cannulas for irrigation aspiration both, and I prefer to do a polishing with the irrigating cannula. And with this, whatever soft some material is left over the capsule will also be washed away. Sometimes you see that there are fibers which are connected to the equator or anteriorly also. That is not the only way to remove all, and all three ports can be used. Some people say that how can you use the main port for these kind of things? If your flow and other things are good and the supported by the machines like Veritas, no financial interest, but these kind of things which are maintaining good fluidics, the chamber is not collapsing even with the main, and this way you can clean all around the fibers. I feel that is not only the polishing, the removing of all fibers is also very important, because this will have a less inflammation, and inflammation also has a role in PCO. The cortical matter leftover is also having a role into PCO. The viscoelastic left behind the IOL is also having a big reason for developing PCO or the folds. And sometimes the refractive surprise that it is the material which is not cleaned immediately in one particular area may have some kind of tilt. Gradually that may disappear, but it may take a longer time of recovery. So the complete cleaning of cortex, complete cleaning of viscoelastic, both are must. I give extra time, and because of this reason that sometimes it becomes boring for the people who are watching the surgery, because I'm doing the same step again and again, and on the microscope I am able to see some fibers may not be visible on the recording itself. So that is the reason that I prefer do a polishing, remove complete thing whatever is visible to you, and try to go beyond 6 millimeter the optical zone. If you just do a central cleaning, the some peripheral fibers will find the way before the cortico so this capsule and IOL addition happens, and this may create a track from which the further sales growth may happen and the PCO may develop little early than actually it could have been avoided. So cleaning more than 6 millimeter is a kind of must. This is a ODC toric lens. No financial interest into the product, but it is giving me more comfortable patients and happiness. So it will increase my practice. I feel so. And because of big tolerance for the refractive error, big tolerance for the contrast, glare, and dysphotopsia, this lens is going to be better than the Synergy and other trifocal or multifocal lenses available in the market. So I think soon this will become a good choice as a first choice. This is already preloaded injector system. You have to just push in after putting the viscoelastic into the proper place. The lens slides gradually, and this is a guarded delivery system, which is my first choice. I am not very comfortable with the shooters, and sometimes it may be an issue that when you are using a shooter, it may have some delivery which is unexpected at the speed, and you can develop some complication of capsule or iris hit. Sometimes hypema happens. So I always prefer having a guarded delivery system by screwing step by step and delivering the lens in the place where you want. We are using Technics platform for more than 20 plus years, and we have found the lens is very friendly for the surgeon in means of inserting into the bag, remaining into the bag, less PCO, and asphericity and other platform has already proven good things. And now the changes into the aslet design and decreasing this dysphotopsia and chromatic aberrations are reduced. The different lighting conditions also keep your vision good, and the lenses are being now more accepted by the people also, and now it is being performed by majority of the surgeons. So that is also one reason that number of patients to achieve a sufficient threshold level of acceptance is being achieved very fast, and these lenses are going to be the future, because I feel given the choice, nobody wants to wear glasses. I'm wearing glasses because of presbyopia, but whenever I will go for surgery, I will definitely not like to wear the glasses again. So that is a important thing the patients are also have in mind. And here I would like to say that many times we feel that the patient will not choose it because of the cost or some other things. And by appearance of the person, we feel that he may not be looking affordable. But when he understands or she understands the benefits, and there are many patients who are actually affordable that doesn't want to show to the doctors that they are very affordable. They are in some fear that I may be charged extra or something. But given the choice options, they understand that every glass is going to cost them. So they also choose for these kind of lenses. So I think the time has come where these kind of lenses that which are not having much of the dysphotopsia, free form of the diffractive platform or a pure refractive platform like Pure C will be the first choice for the majority of the patients. We hope that soon government will also understand that these lenses should not be considered like a luxury by the government and insurance people. And if this game change, then the things will become much more smoother for all the practitioners also and for the patients also. Because when they are going for other surgeries, the insurance people are not thinking like luxury, but here it is a kind of most important health. As we all know, the vision is very, very important for giving the comfort to the living. Particularly, we have a majority of the patients are of old age, and at old age, the independence from glasses or any kind of handicap is a big achievement.
Thank you, sir. Thank you. Excellent surgery, sir. Thank you so much.
Thank you.
That was really very well done. We have our expert panelists.
But I prefer to do complete removal of viscoelastic.
Yes, we also have our expert panelists here, so we have a few questions.
Yeah.
So to our first expert panelist, Dr. Manohar Mehta, sir, wanted to ask you, when you are using the ODC lens, do you target emetropia or not? Or how do you go about it?
Ma'am, I was using Synergy and now I've shifted everything to Odyssey. In Odyssey, I usually target minus target or emetropia.
Okay. Any specific reason why not only emetropia?
We can target emetropia, but 0.5 minus is a better thing is there because there is a wider landing zone is there. So if you overcorrect also 0.5 plus 0.5 to minus 0.5, still the patient have a better vision acuity in these cases.
Okay, so you keep the first minus.
First minus.
Okay, okay. Do we have Dr. Satyaprakash sir and Dr. Rakesh Gupta sir here? Cannot see them. Dr. Rakesh sir, are you there? Yes, yes. So the next question to you, sir, is if a patient has glare and halos, Dr. Satyaprakash sir, yes. If
Yes,
a
ma'am.
patient, yes. Hello, good evening, sir. Welcome.
Good evening.
Yes, sir. So these are diffractive IOLs, and no matter even if the amount of glare and halos compared to the earlier models is less, suppose a patient actually complains of glare and halos immediately post surgery, how will you manage it? And the other eye is yet to be done. So
Madam,
how would you manage it?
Madam, we have to explain beforehand also before surgery that although these lenses are very high quality advanced technology lenses, and there is very less chance that you will be having discomforting dysphotopsia, but still some sort of glare and halos you may be seeing after surgery, and that takes time and neuroadaptation we have to give some time, and we will encourage the patient to get the other eye operated as soon as possible, because we have seen that once the patient is both eye similar lenses, then these complaints are gone down drastically. And with time, passage of time, generally patient becomes very comfortable, and we don't see such big problem in those cases. So that is our. But one more thing, that even before surgery, we should prime the patient. We should not promise complete 100% glare free eye post trifocal surgery, because although the lenses are very good, but some sort, or otherwise if we have not explained that okay, you are not going to get any problem, and even slightest of the discomfort they will be complaining. So what
Correct.
we will explain that you are going to have very good vision at all distances and very less glare or halos related complaints. You will be able to overcome these problems with passage of time, and once both eye are operated with same lenses, then you will not be having any practical problem in your day-to-day life.
Okay, okay. Dr. Rakesh Gupta sir, compared to Synergy, if you compare Odyssey, they say the amount of glare and halos is less. Why do you think it is reduced? What is the reason? Sir, Dr. Gupta sir, are you around? Can't see him. Dr. Virendra sir, would you like to take this question? Why do you think the amount of glare and halos is lesser in Odyssey compared to Synergy?
Actually, every lens which is having some rings for giving the different focal points is the reason for having glare and halos. What they have done in Odyssey is that they have created a special platform by using the kind of dysphotopsia or the glare halos of different kind of rings, in which the height is very important point. So in Odyssey, what they have done is the height is reduced almost to 50%. In majority of the ring, height is less than 50% or equal to 50% of the other lenses. So when you reduce that, it reduces the amount of glare. And for this, the different system have been used by different companies by decreasing or slanting, changing the slant of the ring, making them sharper, making them blunt, and making them having a different height. So by reducing these kind of things, the ring changes, the change in the ring is reducing this kind of night issues. And that's why it is being called as now free-form diffractive profile. There are different diffractive profiles. We are using multifocal lenses almost now for 30 years. And we have seen the development has happened in the technology by having the material change, by having the change in the pattern of the rings they are producing, and by changing the kind of MTF profile. The another thing is that different material is also being used. So different material means that now they are having a better contrast by the change of the material itself, and this contrast also changes the kind of these issues and giving a better vision in the night.
Okay,
So,
Dr. Rakesh sir, thank you so much, sir. Dr. Rakesh sir, welcome. Please unmute yourself, sir. Yes, so compared to Synergy, if we have to compare Odyssey, what is the amount of change or reduction in the glare and halos? So are you more confident now? How much if a patient is come to you and you have to convert him from Synergy to Odyssey, for example? What is the incidence earlier and what is the incidence now in your experience?
So in my experience, I think like I've implanted almost 12 to 14 Odyssey. So what I'm realizing is distance vision is much better than, the distance vision, dysphotopsia wise, patient is much comfortable. Near vision is almost same as synergy. Slightly, the patients are saying, for example, extra 5 to 3 centimeters they have to push hands away. But overall satisfaction is great with this. The best thing is that, like I'm especially recommending it for patients, male patients who are doing reasonable driving, driving in metros. So, like, initially, as a tradition, we are not counseling for, male patients who are night drivers for because of halos. So in Odyssey, I'm quite comfortable advising them. In fact, yesterday only I've operated on a CEO of a big chain of garments, and he regularly drives from Faridabad to Delhi. So I very confidently have implanted lens.
Yeah. So any percentage of incidence would you find a difference in synergy? What was the percentage of glare and halos, and here in
So, see,
Odyssey,
synergy,
what is
I
the
would say,
percentage? Any specific?
so it's very difficult because I've not studied, but synergy only issue was distance vision. Night driving patients were not that comfortable, but because I'm not, it's very difficult to study. But most patients were not very comfortable at night driving. So, and I was not also recommending them. So most male patients I was implanting either POC or VVT. But right now I've implanted all patients are like like. Yes, the patient which I mentioned is he's a 54-year male, but and it was a clear lens suction actually practically because that was a press back lens suction only.
ये किसका लगा है अपना है कि नहीं?
He's quite comfortable.
Okay. Dr. Manor Mehta, sir, one question to you is, have you put these lenses under BSS also, or you always use a viscoelastic in these cases?
No, ma'am, I use viscoelastic. I use conducting sulfate, viscoelastics only, not in along the saline.
Okay, okay. And see, many of them are saying they are tolerant to refractive errors. It has been found that with diffractive IOLs, one of the important causes of glare and halos immediate post-op is because of a residual ametropia. So, what is your thought on this?
कल तक ने वीकेंड नहीं, तुम रोज ऐसे कर रहे हो, कल 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 कल.
Hello, I didn't got, ma'am.
Yes, yes. No. My question was, I think Dr. Virendra sir and Dr. Rajiv Chaudhary sir also mentioned that this lens is quite tolerant to a residual refractive error.
Residual ametropy.
My question,
Yes.
My question is,
Yes,
one
ma'am.
of the major causes of glare and halos in a patient with diffractive IOLs is residual ametropia.
Yeah.
So, in that sense, would you prefer that obviously we would prefer emetropia, but if there is a residual refractive error, then definitely there could be a chance. So, what is your thought on this?
Please, here the landing zone is little bit bigger, so that's why if you keep a 0.5 or plus or 0.5 minus also, you will have a better chances of getting emetropia in this. 6 by 20 by 20 vision in these cases. The defocus curve is better in these lenses.
Okay.
Yes.
Dr. Rajiv Chaudhary sir, one last question to you. Have you also used other lenses like you have, for example, the Galaxy lens, which also is a presbyopia correcting lens, and that is a non-diffractive kind of. So, what is the difference you have found between Odyssey and that lens?
Basically, I have used that Synergy, Panoptics, and then now Odyssey. The Panoptics also have the good.
I'm talking about the Galaxy Rainer, sir. That
Galaxy
doesn't
Runner
have
we
those
used, but
thicker
I have
lenses.
not
So,
used
what
Galaxy Runner
have you
much.
found any difference?
Galaxy Runner I have not used much because we stick to our few lenses because we also become comfortable with that lenses, and we can confidently offer them the patient that what we are having the experience.
Yes.
So
yes.
I have
Anybody
experience
else
with Panoptics, Synergy,
Yes,
and then URC.
Yes, sir.
Anyway, we are going to
Anybody
have
would like to answer? Then we can go ahead with the next surgery. Yes, sir.
Yeah, I used for trial some Galaxy lenses. I'm not able to show definitely for a long-term results what they will do, but on table we are able to see the rings. So diffractive rings which are visible on a microscope, and believing that they will not cause any kind of glare and other things is not acceptable. What I mean is that the different lenses have a different glare profile, like we have seen from the bifocal, multifocal, trifocal to shifting to synergy, then to ODC, they are having some changes. But the few patients I have done for Galaxy, I am not able to say about the results on eye trace and other features. But the things which are visible on table itself can't give you confidence that they will not be having an issue like this. It may be slightly less, slightly more in one particular lens, but can't be zero. So
Yeah, correct. Of
nothing
course.
against
Yes,
anybody
yes.
or nothing for financial reasons, but I
Yes,
think,
yes, absolutely.
yeah. So time has
Yes,
to
yes.
prove that they are going to be how much different than the current lenses we are using.
Yes, sir, sure. So shall we have our third surgeon now? Dr. Amit Mishra, sir, are you ready? Can we start the surgery, sir?
Good afternoon, everybody. I'll just share my screen.
Yes. Yes, we can see your screen.
So this is a patient who is a 71-year-old male, and he's a passionate wildlife enthusiast. Particularly in low light condition, his demand was that he used to do photographs. So we counseled for the refractive aid of IOL, and we explained him that with a few near, but he might still require glasses. Preoperatively, topography, eye trace with Barrett formula. These are our standard thing. And now I shall be starting the surgery. So the patient chose flax. We did flax on the catalyst platform, where the capsulotomy is in just 1 second. And the corneal incisions, I do not do with the flax. I make with the keratome and the paracentesis. And after flax, we have always stain with the trypan blue dye to delineate the capsule. And after staining, the viscoelastic is being injected. And the main port is being made. Now, one can observe that this is almost a free-floating kind of CCC. The size is around 5.2 millimeter, which gives rise to a good centration of the IOL. We have used a 6-cut radial profile, and stepping the lens takes out the air trap behind. Now, we are using the Veritas system over here for the phacoemulsification. And since the lens is already been divided into different planes by the laser energy, the energy used is quite less in Veritas. And the suction over here, which I am using, is 400. I am a high vacuum surgeon. Dr. Virendra has mentioned that he's a low vacuum surgeon. I usually prefer doing a high vacuum surgery. And even on this high vacuum, the Veritas system with its compensatory IOP maintenance does not allow any fluctuation of the chamber. So the pieces are already divided by the laser. I'm just separating it with the help of engagement and then emulsifying the nucleus pieces, bringing them into the center. In this patient and some of the patients in flax, we have observed that the pupil size usually goes down. But right now, I do not think any requirement of any intracameral mydretic, because I'm able to comfortably take out all pieces. Here we are using bus mode. And now one can observe that the handpiece is in the center and all the pieces, the followability and the emulsification of the pieces is wonderful with this system. And within no time, most of the nuclear fragments are being emulsified. Since the pupil is still being lower, we're injecting some phenocaine intracamerally to achieve an optimal dilatation. again, a bimanual irrigation aspiration is being employed to remove the residual cortical matter. And in femto also, we have observed it's fairly easy to remove the cortical matter. One has to just pull towards the center after pulling laterally from the rhexis margin. One should avoid catching the iris in these, especially in these premium cases. I have caught it twice, maybe because of the small pupil, but one has to be careful regarding that. Dr. Virendra has beautifully demonstrated the capsular polishing. I have learned the capsular polishing from him. Especially in these premium IOLs, the polishing of the anterior as well as posterior capsule of any residual lens fibers or cortical matter is of paramount importance. And we are using sandblasted cannulas. In the interest of time, I'll just skip the polishing part since Dr. Virendra has already demonstrated a very meticulous and clean polish. Now, we are injecting the pure C toric IOL in this patient. And though the cylindrical error is just 1 diopter, but since it is at 90 degree, and I believe in correcting even the low astigmatism also. So the simplicity injector delivers the lens in the back. The lens opens up, takes its time. Now this is EDOF lens, which is where the anterior surface is aspheric, and the posterior one, there is a continuous change in the power, which gives an elongated focal length of the EDOF profile. And the difference between this lens and the other lens is we do not see that central bumping of the EDF IOL, which many of the other brand lenses are having. So removal of the viscoelastic from behind the lens is of paramount importance, especially in toric IOLs. And this is also having frosted haptics, which gives a good rotational stability to the IOL. We are using online stabilization for the placement of the lens at the correct axis. Now, the dysphotopsia profile is almost comparable to the monofocal lens, and one of our resident is doing thesis on pure C versus another EDOF lenses, where the depth of focus and contrast sensitivity, we have found it to be better in pure C lenses in comparison to other brand EDOF lenses. So after meticulously removing all the viscoelastic, we will place the IOL on the axis. And once that is achieved,
yes.
So I think that concludes the case.
Yes, yes. Thank you so much, sir. Very, very good. Excellent demonstration, sir. Very nice. Dr. Manohar Mehta, sir, a question to you on this. Yeah, regarding the pure C lens, how much is the near add that is required in your hands or in your experience?
I have implanted quite of pure C lenses, ma'am. It gives usually innate comfortable it can give at in the 40 centimeter it gives N6 also, but it needs some time +1.
You need a +1?
+1, yes, ma'am.
0.5 or to 1, yes.
1, yes.
Yes. Dr. Rakesh Gupta, sir, do you use micromonovision in these patients or do you target emetropia in both eyes?
I'm putting first my pick in like up to around -0.4 to 0.5 in the second eye, and practically 60% of patients are actually reading N6. They actually stop using glasses, though at 3 weeks we do advise +1 as Dr. Manohar said. But practically over last almost 1 year, I've seen they stop gradually using glasses. They adjust their distance according to the their focus in mobile. But yes, +1 is the idea where most patients settle down.
Correct. Dr. Tiwari, sir, is that? I couldn't see him. Okay. Dr. Virendra, sir, if you compare the defocus curve of Odyssey versus Pure C, what was your thought on it? If you compare the defocus curve of...
Theoretically, I will speak, I have not done it that way. But what I mean say that the Odyssey gives you more like a continuous and full form of vision, means once it starts giving you near vision, it is there. the POC also works from one particular distance to distance seamlessly. But the near point of vision is little less in the POC, means you have to keep little far away. That is one thing. The second thing I would like to say about you said that the not having a pure emmetropia in these kind of lenses. So usually monofocal lens, when it goes into hyperopia, it behaves like a plus power lens requirement for the reason because it does not have any kind of changing the image quality from one point to a near point kind of thing. So when you work like a emmetropia to near vision, there is some depth of focus is increased. And by having a little plus or little minus, it maintains the good kind of distance vision, may not be exactly 6x. The quality and crispness of these lenses compared with the monofocal lenses for 6x may not be that crisp. But when you talk about the practical thing, they are behaving like a monofocal lens for distance, even with the 0.25 or 0.5 diopter of myopia or hyperopia. Is the main advantage that you can keep for POC and ODC a little myopic aim, and for synergy more like a emmetropia or slightly on a hyperopic side of aim, as it was suggested by the company and theory. But for synergy also, my first choice is the emmetropia or a first minus kind of lenses to add on the advantage by giving a near vision at even 30 or 25 centimeters in some of the patients. And we Indians don't have a very arm length is a little short, not very long. So these kind of minor modifications are making majority of the patients independent of glasses for all their work. And the same thing I carried over the OTC, and I found it was not my belief that they will give this kind of near vision, but I realized they are giving the same near vision as it was there with the synergy. And POC is not able to promise for everyone, but because not having any kind of other issues of optical phenomena like dysphotopsia and no negative thinking that sometimes patient says that if I see ring, I will not have confidence to drive. So here what I do is that my first choice is still a diffractive lens. The refractive lens is for the patients who says that, sir, I am very much afraid of. So I ask the question that it may be kind of a personal question, but if you agree and tell me that if any kind of thing happens to you, do you really become panic and you can't forget it, you can't tolerate it, then I will not do a diffractive lens. Otherwise, first choice is a diffractive, second choice is pure refractive.
Okay. Dr. Mishra, sir, would you still continue to use Synergy now, or would you go completely over to this?
We have been seeing fantastic results with ODC currently at our center. POC is being reserved with as Dr. Virendra has rightly mentioned, to a select group of patients who are averse to even a slight problem or slight dysphotopsia with the lens. Having said that, with the even emmetropic bilateral implantation of POC, we have seen many patients fairly independent of glasses. The only issue with POC, though the company claims that it is pupil independent, but in our scenario, especially in old age patient in Indian eyes, the pupil size does make a difference in selection of these refractive POC lenses also.
Yeah. Dr. Manoj, sir, do you feel what is the spherical aberration of these lenses, both POC and the ODC?
Very less one. Both the spherical, because they are on aspheric profile platform, so don't have much of spherical aberrations in this.
No, is it the same as the minus 0.27 like in the Technis one?
Technis, same, almost same.
It has the same Technis platform. So, right. How much importance would we give to the angle alpha or angle kappa, Dr. Rakesh, sir, in case of ODC and POC?
So I'm following the rule of 0.5, in all the cases. But yeah, there are some cases. For example, I operated lately on my relative who underwent PRK for -5 long back. So in one eye, I implanted IHANS, and second eye, I implanted POC. So she is complaining of some dysphotopsia, but over a period of 3 months, she improved. So, and her angle kappa was high, and but she was insisting for the best possible IOL. And over 3 months, she improved that. So I believe somewhere neutrodepletion is a phenomenon which we always ignore. So ideally we should follow that 0.5 rule, but because she was my relative, my bossy, and it was like 0.7 somewhere around. But she's very happy after a period of I think 2 to 3 months. she has improved, and now she is reading almost N9 and 6.6 in that eye. In Ihans eye, I mean, she needs 1.5 addition, but in eye with the pure C, she is not requiring any aid at all.
Okay, would we recommend the use of both these lenses in pediatric age groups?
So-
Dr. Rajiv Chaudhary, sir?
Depending on the pediatric and the early age, probably it's because the changing refractive error make the lens not good for them. So monofocal will be the idea. But if the age of that is 14, 15, then you can definitely try EDOF lenses, either pure C or ions, so that you can give some depth of focus to them. And later on, if the refractive changes, you can go for the LASIK or bioptics, something like that.
So, but in Ihans, we have the central, the area.
Yes,
So
yes,
in
yes.
case of there is decentration
But
over the years, then would it make a difference?
It definitely will make the difference, but this decentration and that power is very less. So we can give in some depth of focus to that child. Not too young, so
Yes, I mean, less than, say, 11 or 12.
less than 11 will not okay, because then the
Not so,
refractive error
yes.
changes too fast.
Correct. What about post-refractive surgery cases, Dr. Manoj, sir?
Post-LASIK
cases,
post-LASIK cases, we need to prefer PUC, ma'am.
Definitely, yes.
PUC is the better option in these cases.
Would you go in for a pure C or would you stick to a pure monofocal lens?
Pure C. See, ma'am, if you target monofocal, anyway, you may not get a 20 by 20. But if you target with this one, anyway, there is a landing zone of plus 0.5 to 0.5. So you have a better chances of hitting the target with the pure C in these cases.
Okay, one last question to all of you. If it was your eye, which lens would you choose? Would ask everybody to give their
Correct
thoughts.
scenario, I can start with that I will prefer pure C, because OTC is just introduced. We have not seen the long-term result, and pure C give the good depth of perception. And if you need a minor glasses, it will be okay. So you are free from glare and all that.
Dr. Virendra, sir?
Yeah, my choice also will be pure C, and there are few reasons for it. One big reason is that the glare and halos may affect the quality of work we do, like for the surgery and other things. And I, being the refractive surgeon, still do refraction of all the surgical patients who have to go for Smile Pro or something myself. So I feel that these kind of diffractive lenses may affect some quality of my picking up the things. Otherwise, also many patients I pick up like a keratoconus by just simply showing the retinoscope to them once, while just chair is being pulled up by the level of slit lamp. I do retinoscopy, and by that I picked up many keratoconus. So I'm just afraid of that might be missed. So any kind of ions or pure C will serve my purpose, being a refractionist also, and not having any other issues which will affect the quality of vision during the surgery. That is the reason of being the first choice. But when it was not so, means when these lenses were not so, I was ready for multifocals. So I'm not saying any negative for the multifocals, even for surgeons. I have eye surgeons, and particularly non-eye surgeons like gynecologists and surgeons are very, very happy with diffractive lenses.
Yes. Dr. Manoj, sir?
I'll prefer one eye ODC and one eye pure C, and I will leave it or neuro adaptation. Anyway, neuro adaptation is going to take. I'm going to enjoy the both of the best world. Why not? Okay, have you already done that in some patients? I have done for one patient. He's very happy. Both eyes very happy. First eye pure C I have done. By choice, I have done one pure C, and then later I have given for him this one. He's very ultimate happy. Dr. Rakesh, sir?
So see, I'll say if I get my cataract surgery during my active life, obviously pure C will be my lens of choice in my eyes. But if I get cataract beyond my operable, as long as I'm beyond my active surgical stage, then I'll prefer to go with diffractive trifocal IOLs like ODC. I'll prefer that because definitely the spectacle independence, something like I'm using presbyopic glasses since last 5 years, and it's actually a headache. But once we start using it, we realize how much a problem it is. So, but yeah, as if I'm operating, so I will be more comfortable with the POC.
Non-diffractive. Okay.
Not different.
Dr. Amit sir?
I'll definitely go with the POC in current scenario, and my insurer would also cover it. The choice given of LAL, then I'll go for LAL.
Sir, why are you looking?
Insurers usually do not cover the multifocals, but the EDOF is being covered by them.
Okay, would that be one of the factors for you?
Yeah, of course. For my patients, that is one of the biggest factors.
But for your company, will take care. Don't worry. You don't need to
JNJ wale suno bhai.
Dr. Namrata ma'am? I think she's busy. Okay. I think we have had a great session today, and I think with the newer kind.
One last question,
Yes.
Anga. What is your choice?
My choice is PRC, sir. I actually love that lens. It's, I think, with the non-diffractive platform and with the improved contrast sensitivity and with minimal glare and halos, I think that gives very good functional range of vision. And even if we have to use just a plus 0.5 or 1, it doesn't really matter. But I would feel the quality of vision is probably more important to me.
Okay.
Anyway, I don't drive, so doesn't matter. We all have drivers, so that's not really that much of an issue. But even for our daily work, I think that contrast and clarity is more
especially
important.
surgery, especially doing surgery in the microscope and light and all that.
Correct.
Once we start using presbyopic glasses, then we appreciate like I'm using plus 2.5. So even going to POC with plus 1 addition will be a boon to me.
Will be a boon. Absolutely. Absolutely. Dr. Virendra sir, you want to say something? Yes, sir.
Yeah. So Anaga, as you were saying that we are having a question about the Galaxy and other things. The Galaxy also claims to be a refractive lens. And we had a refractive lens platform like Resume and Array. I don't know how many of you have used. I used many. And they were also showing the almost similar kind of rings. They were also refractive, but not a form of pure refractive. So I feel theoretically the difference may be in POC, you are having a continuity of a refractive change. And while in Galaxy, it may not be that smooth. That's why we are able to see rings on the microscope. And when it is not going to be a continuous and very smooth one, it will have some or other form of dysphotopsia, which may not be to the level of like routine multifocal or bifocal trifocals, but definitely it will not be equivalent to other kind of EDOFs like we have this of POC. There is no financial return, but when we have used VVT also, we could see the rings, and some of the patients were saying that I am seeing 1 or 2 definite rings. So these kind of things may be less than those, because like Synergy, ODCs, you see multiple rings. But with EDOF lenses like VVT, you see few rings. With Galaxy, it may be same or it may be few, but may not be equivalent to POC in sense, because we are not seeing anything on the POC, such kind of optical phenomena during surgery.
Yes, sir, they are different. The Galaxy has rings, but they are very subdued. It's not that it is without rings, and the glare and halos are also there, but they claim it is much lesser. Anyway, I think today we all have, I mean, compared to a few years ago, we today have so much of choice. And I think more the choice, on one side, it is easier for us to pitch to our patients. On the other side, the patients get even more confused. Because when they go from center to center, and today there are a lot of patients coming for second or third opinions, each doctor would give their side of the story. So I think it is more important for us to be ethical and explain to the patient what exactly he is in for whenever we are recommending a particular kind of lens. So all the more, I think such Surginars are so important for us to share our knowledge and wisdom and pearls of experience with each other, as well as to translate that into counseling to our patients. So I think our counselors also need to be trained in all this, because with the advent of newer lenses coming in so frequently and so quickly coming together, many times the counselors may or may not speak in the same language as we would. So thank you, everyone. I hope Dr. Namrata ma'am is there around so that we could finally conclude the session. So I feel thank you so much to each one of you. We had great surgeries demonstrated by Dr. Rajeev sir, Dr. Virendra sir, and Dr. Amit Mishra sir. And thank you for the expert comments, Dr. Manohar Mehta sir and Dr. Rakesh Gupta sir, Dr. Tiwari sir for this. And thank you J&J for this Surginar. Thank you so much, Namrata Sharma ma'am.
Thank you. Thank you all.
Thank you so much.
And Anaga for arranging such kind of free webinars where the things
Thank
can
you.
be shared without financial reasons. Thank you.
Absolutely.
Okay, bye.
Thank you.
Thank you.